Good evening, everybody. My name is Mary Vicarious, and I'm back with you for this course on trauma-informed care. So again, it's really an honor to be back with you. And as I told you last week, I came to Dallas in March and trained there, and also got to go to your space and was really, again, blown away by how wonderful it was. I know since last week I've been paying attention to the news. And for those of you who are sports people, I know that Mike Napoli was traded from Boston back to the Texas Rangers. Now, I don't know if that was traumatic for him. We had somebody in New York who plays for the Mets who thought he was going to be traded, and he started crying out in shortstop. So also, Aldon Smith, I heard that the Dallas Cowboys are trying to get him. He was a gentleman we could have probably talked about last week when we did co-occurring disorders, and he will probably, hopefully, get some treatment and then will maybe play football again. So again, I'm glad to be here. So everybody's here. There I am again. I'm wearing the same sweater as last week. No, it's really hot in New York City. But as I said, my name is Mary Vicarious, and I've been in the field for many years. I am a vocational rehabilitation counselor by trade, and one of the reasons I'm doing this course on trauma-informed care is because trauma often is connected to co-occurring disorders. So this even is a good, I think, follow-up to the course that we did last week. So here we go. The goals of this course, and let me just preface this with that sometimes it's really difficult to sit in a course on trauma. Why do you think that's true? Because not only have our clients have experienced trauma, but many of us have experienced trauma as well. So what we will do tonight is, and here's 3 goals, to help providers, you all, understand the scope of trauma, some of the definitions, some of the impact of trauma on their clients. I see, oh good, I see a question. John is curious about how much experience you have had with trauma-informed care. Good question. I have been doing training on trauma-informed care for the past 3 years, and I've also done some training and some technical assistance in helping agencies figure out how to work with trauma-informed care in their agencies. So does that answer the question, John? Good question. Thank you. Good. So we'll be looking at, again, as I said, some of the definitions and the impact. We'll also look at a large scale case study, and that's the ACE study. Some of you may have heard that before. It's called the ACE study. It's about adverse childhood experiences, and we'll talk about how that study is correlated to some of the illnesses that impact our people today. And then also we'll increase our knowledge about trauma-informed care. So we'll start with some of the pieces on trauma and look at trauma-informed care and some of the things that you can do. So here's the working definition that we use, and as it says up on the slide, what is trauma? You know, I'm going to say that I purposely don't put a lot of pictures of people showing traumas because I don't want to traumatize you all as you're sitting in the room in Dallas. But here's the definition we often work with. It's an event, or it really can be a series of events. So the personal experience of an event that involves actual or threatened death or serious injury. And sometimes, for example, somebody may think they're going to die, even though you might look and say, oh, well, that's not so serious. But for the person, and it's really subjective as to how they view trauma. It can be, as I said, an event. So for one person, it might be sexual assault, or it could be that a series of events. So somebody who might have been sexually abused as a child over a long period of time, or somebody who's been bullied for a year. And the key is often that the person's response involves fear, intense fear, horror, and hopelessness. And it really is a certain subjective things. And for example, you may have known 2 clients who experienced the same trauma. One person may have been traumatized, the second may have not. And then we wonder, well, why is that? And it really speaks to some of the resiliency factors that people have. There were two women in New York. We had Superstorm Sandy, and there were two women, both of whom lost their homes. One woman was traumatized, one was not. And when they looked at some of the background of the woman who was not, guess what? She had a lot of resiliency factors. So she had a lot of social supports through her family, through her church, and she did not suffer as much as the woman who did not have any of them. This again is just really a picture of the event and how people respond to it. And again, we did that fire, we did that as an ambiguous drawing on purpose because we didn't want to traumatize you. It used to be, for example, in New York City, people would always be showing pictures of the Twin Towers burning, and sometimes you'd be in a training and you wouldn't be able to concentrate because of it. So these are some of the reactions, and that the reactions really are key. So now I'm going to ask you some questions, and there's two questions up there. Let me try to start with the first one. So what are some of the kinds of traumas that your clients have experienced? What are the kinds of traumas your clients have experienced? So I know there's 34 of you and one Sarah typing. So what are some of the traumas that people have experienced? Definitely psychological. Sexual assault, again, a big one for men and for women. Financial. Actually, losing a job can be traumatic. Never having a job can be traumatic. Being on public assistance can be traumatic. What other ones do you have? Physical trauma, definitely, with people either getting beat up or by people they know, by people they don't know. Emotional trauma. So you're really starting to kind of hit the gamut from the biological pieces, probably the psychological, and some of the things too. Actually, I'll ask another question, but what do you think are some of the unique traumas that might occur as a result of homelessness? What are some of the unique traumas that might occur as a result of homelessness? And probably for a lot of people, being homeless is traumatic, right? Having no money, lack of jobs, and we'll be doing something on supported employment on Thursday night. Any others you'd like to add? I have a few that I've written down. Oh yes, living in encampments. I know for a lot of people tell me that if they're exposure, but I remember people telling me that living in a shelter can be traumatic, that sometimes people would rather live on the street than in some of the shelters, at least in New York City. And I was thinking, for example, of sleeping on the street, bed bugs, traumas at shelters, people's reactions to them. So sometimes as somebody is homeless and they're in the street and they see how other people are reacting to them, that can be traumatic. The onset of other illnesses as a result of homelessness. So there could be, again, so many that we have, or that many of the clients have experienced. This is a chart that has some of the kinds of traumas. This comes, by the way, from a book called TIP 57. TIP stands for Treatment Improvement Protocols. These are free books, by the way. And this is tip number 57, and I'll make sure that tomorrow I can give you the phone number. You can actually go to the SAMHSA website. For those of you who were in the training last week, SAMHSA stands for Substance Abuse and Mental Health Services Administration. And you can download them, but you can also call them and you can get the books for free. And they broke down some of the different kinds of traumas into natural causes, into accidents, and intentional acts. And I'll start asking you all some questions as we go through, but as you look at some of these, So we have the natural causes like earthquakes, hurricanes, tornadoes, floods, tsunamis, famines, accidents, train derailments, aircraft crashes, car accidents, radiation leaks, oil spills, accidental gun shooting, intentional acts, and notice that that side seems to be full, and you could probably add other things there like terrorism, arson, homicides, suicides, domestic violence, school violence, bullying, genocide, physical abuse or neglect, sexual assault or abuse or warfare. So there's a whole, I guess, pretty, I won't say it's comprehensive, but it's fairly comprehensive, and there are probably others that could be added. I was thinking, for example, of oil spills. So I know that in New Orleans there was an oil spill, or some of you, depending on your age, and I can't see what you look like or how old you are, but if you remember, there was an oil spill in Alaska. It was the Exxon Valdez, and one of the things that happened was, because there was so much oil, the native people who were living there really depended on water. They depended on water for their living because they were fishing. They depended on water for their healing. And so the accident, quote, accident, I'm kind of making a face as I say that, really impacted people in terms of their culture. When you look also at, well, Katrina was something that some of you dealt with fairly, not too far ago. But I was thinking even recently around some of the stop and frisk policies. So for a lot of people, they have been traumatized, and it may look like what happens to people every day, but we don't really want to minimize that as well. So I guess what I could throw out are any reactions as you look at that list. So it's a list of natural causes, accidents, intentional acts. What stands out for you on that list? Oh, the train derailment. Did you have one recently in Dallas? I know there was one, an Amtrak derailment recently in the Northeast, and one of the trains was derailed and a lot of people died. Others that stand out for you? The tsunami, right? Remember, oh, earthquakes. So again, some of the natural causes, and you know, anybody here, if you watch television, all you have to do is almost every week there is some kind of traumatic event going on, whether it's a natural cause, when you look at what's going on in terms of some of the weather throughout the United States, or accidents and or intentional acts. And probably if you watch the news, they kind of hope that you're paying attention, or they kind of hook you in by looking at some of the traumas that happen. Let's go then from some of the kinds of traumas to also looking at what might be some of the differences between trauma for men and trauma for women. There is a woman named Stephanie Covington who's done a lot of work on looking at women and trauma, and she started first looking at women and trauma. She's somebody you can Google also. And then she was asked by Hazelden to do some work also on men and trauma. And this is some of the things that they saw. What you see in terms of the commonalities is both men and women have high levels of traumatic experiences. Make sense? Here's the difference, though. A lot of times when men are reporting physical violence, it's violence by strangers. So sometimes it could be a gang war, sometimes it could be somebody who beats them up, but it's usually people that they don't know. Here's one of the differences for women. Women are more likely to report interpersonal physical or sexual abuse by people they know. So when you think about that for some women who've been abused by family friends or relatives, it really takes away a woman's sense of safety. Now, it may be a generalization because some young men may have been abused by family members as well, but those are some of the things that Covington talks about in the differences. Now, for those of you who were here last week, We talked about the DSM-5, the Diagnostic and Statistical Manual of Mental Disorders, and these are two of the disorders that people might get a diagnosis of. But it's also important to realize that you can experience trauma, and a lot of people heal from trauma, and I think that's important to look at. So not everybody gets a diagnosis, but some people get a diagnosis for acute stress disorder, and I'm going to guess that many of your clients are dealing with post-traumatic stress disorder. The key, and actually some of the differences, really has to do with time. So acute symptoms, 4 weeks or less, so less than a month. Post occurs after the event, and the new DSM-5 criteria include things like intrusion. What that means in plain English is that sometimes people will be having flashbacks, and flashbacks are memories that people have without distance. Sometimes they'll avoid the place where they were abused. Now that can be helpful too, by the way, but if it also can make somebody dysfunctional. They'll have negative alterations in cognition and mood and alterations in arousal. What that also means in plain English is that sometimes clients or people who have been abused are hyper aroused, so that sometimes if you just touch somebody and they jump, it may be that they are kind of always on and always waiting to see what happens. One of the things that they did in the DSM-5 PTSD, they took away that you had to have a lot of fear, and the reason they did that was because first responders are trained not to have fear. So what's complex trauma? Complex trauma is really common among many of the clients I think that you work with. It's the experience of multiple chronic and prolonged developmentally adverse traumatic events, most often of an interpersonal nature and early life onset. What does that mean in plain English? Is that many people have experienced many traumas, and for a lot of people, they may have experienced traumas when they were young, but nobody was really paying attention. So you may have somebody who was dealing with sexual abuse as a child, now they're dealing with domestic violence, then they become homeless. So those are all kind of the complex, or the term is also used, multiple traumas. So here's a question for you. What percentage of your clients have experienced trauma? What percentage of your clients have experienced trauma? Who says A, 0 to 25%, B, 26 to 50%, C, 51 to 75%, D, 76 to 100%? What do you think? So if somebody would start to either count either the A, B's, C's, or D's, or you can give me just some ballpark figures, and then maybe, Sarah, you can type them in, please. Oh, C. Okay, so I see that a lot of people say 51 to 75%. Is that what most people think? So the majority is C, and actually that's pretty, oh, D as well. That's what I would have guessed too. So that we're really talking about high levels of people who have experienced trauma. So let's go to the ACE study, or the Adverse Childhood Experiences. I'm not sure if people have heard of this before, but it's something that when people are studying about trauma, they look at this study. And here's just some, I think, some interesting information about it. It was a study that was done by Kaiser Permanente, and the two doctors who did it were Anda and Filiti. And these doctors, they started this study in 1995, and you're saying like, well, what do we care about something that was so long ago? But what happened was they were working with, in the 1980s, with people who were obese, and that was before bariatric surgery. So what would happen is women and men, would come to their site, and they go on these liquid diets. And they had two women, both who were sisters, and they both each lost 150 pounds. So they were like really happy and said, this is great, you know, this is a success story. Unfortunately, they found out that 8 months later, both of the women had gained the weight back, and they were wondering like what happened. So they said, well, they're sisters, so maybe it's genetics. Both of the women were Latina, so they said, well, maybe it's a cultural thing. But then they found out that both of the children, or both of the sisters, had been abused, had been sexually abused by their father. And that's why they continued to gain weight, because it became for them kind of a security blanket, or they felt that if they were obese, that they wouldn't be sexually attractive to their father. And unfortunately, that didn't work. So what they did was they said, you know, we're doing things wrong. We should have asked these questions ahead of time. And they did a survey, as it says up there, of about 17,000 participants of Kaiser Permanente. And here's some of the questions that they asked. Now, they asked 10 questions, and let me say, I was at a training once for drug court, and Stephanie Covington had us all answer the 10 questions. And unfortunately, as we were all answering the 10 questions, you could see everybody starting to like cover their paper. And this was people who were judges, who were public defenders, who were DAs and case managers. So I usually say, let's not answer the questions for yourself, and I'm just going to show you 4. So here's one of the first questions. Did a parent or other adult in the household often or very often swear at you, insult you, put you down, or humiliate you? This is all before the age of 18. Another question is, did an adult or person at least 5 years older than you ever touch or fondle you, or have you touch your body in a sexual way? Another question is, were your parents ever separated or divorced? And one of the things too is they did this study or it's been replicated in many countries, and different countries have really different views about divorce. And they found that when they did the study in Taiwan, that people had a lot of shame about divorce. So that may be different than here in the United States, but even within your own cultures, that may be. So it's one of those it depends answers, but many people put a lot of pressure on that question in some of the other countries. Did you live with anyone who was a problem drinker or alcoholic or used street drugs? So again, it went through the questions, and what they found was the more a person said yes to the questions, the more they looked at a correlation with other physical illnesses that people had. Now, is anybody a football fan out there? You could say yes. Now, I'm not stupid, so I'm not going to use an example of one of the Dallas Cowboys, but I had used or talked about Marshawn Lynch last week. Now, I don't know him personally, by the way. He plays for the Seattle Seahawks, and so I got my information about his ACE study results based on a show that he was on at ESPN. So, as you may know, Marshawn Lynch does not like to speak with anybody on TV, so or with anybody. So one day he was speaking with somebody at ESPN, and he was talking about what his life was like. And in my mind, I was kind of going through the questions of the ACE study. So he talked about growing up in Oakland in a really poor community. It's like, check. Then he talked about how his father left his mother at an early age, but he was often sent to stay with him for the weekend. And what would happen was he would go to visit his father for the weekend, but then his father would disappear. And so Marshawn was a young boy hanging out by himself, and then he returned to his mother's house. We find out later on that his father had a drug problem, and that also his father, I think, is now in prison. So if you look at his ACE study, but don't tell Marshawn I said this if you see him. I got it all from ESPN, so I'm not breaking any confidentiality law. But it really speaks to, again, and he's probably no different than many of the clients who we work with, who have experienced a lot of traumas, and just look at it as part of the kind of the normal way that people are expected to grow up on. So this is just a kind of a pyramid of, if you look at adverse childhood experiences, for some people, they have social, emotional, and cognitive impairments. As a result, they may adopt health risk behaviors like substance use, and or lots of unprotected sex. They may develop disease, disability, and social problems, and for some people, they will die early, unfortunately. What you see, by the way, and this is it in words, but when they found out is the higher the score, the more it correlated with depression, suicide attempts, substance use, multiple sex partners, perpetration of domestic violence, liver disease, COPD, which is about lung disease, heart disease, shortened lifespan. And I mean, one of the challenges is the key is that it correlates. So we don't say that it causes, because somebody, you say, how could somebody get, a lung disease as a result of some of these adverse childhood experiences? But what could have happened was somebody started smoking cigarettes early on, and then they developed lung cancer as a result of that. So these are some of the things, and some of the agencies that I've worked with have started to use this early on when people come in. So they ask the questions so they can start to get information about trauma early on. Now, you look at that heart, by the way, here's something to keep in mind, is that trauma doesn't just affect our clients. And many of you may be familiar with the term vicarious trauma, and this is what it is. So people who work with people affected by traumas may be vulnerable to vicarious trauma. If I were to say who here hears stories about people's traumas most of the day, I would guess that most of you would raise your hand, and that would include, I think, some of you, like the security guards, as well as some of you are counselors or case managers. And what happens is that for sometimes as you continue to listen to people's stories, that you can be affected by it as well, even if you haven't dealt with the same trauma that you're hearing. So it's cumulative. It's why hopefully people are taking vacations and taking good care of themselves, because it's an important piece about vicarious trauma. Some of the effects, you might start to feel fear or vulnerability. You might have difficulty trusting. One of the challenges, by the way, is when your job is so stressful, it also affects how you act at home. The difference between burnout and vicarious trauma is that if you take a couple of days off and you feel better, that could be burnout. But if you take a couple of days off and you still are not really feeling good, that could be vicarious or secondary traumatization. So how do you address it? Hopefully, well, actually, you're having a staff training as we go along, and hopefully people are getting some clinical supervision. It's really important. Here's the key is, as some of you might have learned this in school or you haven't, but you really have to deal with your own traumas before you can deal with other people's, because sometimes we'll talk about countertransference, but a client could be telling you a story and it may be something that you experienced, and that can be really challenging. So it's really helpful to deal with your own stuff before it'll help you be healthier around that. So then you need to be aware when the client issues exacerbate your own personal issues. So that's kind of the quick thing. You could actually, some of you probably have had courses on self-care, because that's really important, taking care of yourself. But vicarious trauma is an important part to work with. So looking at the clock here, it's 10:30 in New York, it's 9:30 at your place. Let's then get into, and we started to talk about trauma, but now let's talk about what is trauma-informed care. And this is a term, it's kind of one of those buzzwords that everybody's using. And here's kind of the working definition that we use, is that it is a systems approach. So it's really looking at your whole system, kind of from top to bottom, to look at how you create safety. And it could be something like, do you have lights? You all actually have some, I think, a really beautiful site, and but sometimes people will go to agencies where the lights aren't really good, or there's no security system, and you all have that. So it's really about creating safety and training people on trauma, training staff, because trauma, as you said, can impact all the clients. So it ensures safety in all interactions and physical space. And here's a couple of things. They say that we should assume that everyone has experienced trauma. And one of the things happens is that sometimes we re-traumatize people without trying it, without trying to. Sometimes if we're rude to people, or sometimes if you have a loud voice, or we don't treat people with kind of those core qualities of counseling, we can re-traumatize people. There's a saying that says, hurt people hurt. So, sometimes a client or a guest, they're giving you a hard time. Sometimes when I think that hurt people hurt, that can be, I think, helpful to keep in mind. Also, sometimes people are doing the best that they can, and they're trying to protect themselves in the way that they know. And I'll give you an example. There was a situation at a drug treatment center that I had done a training at, and it was a place, it was a residential treatment center. And so one of the young women was reprimanded by a counselor, and he spoke to her in a loud voice, and she felt disrespected. So one of the first things she did was to go back to her room, and she hid under the bed. Now, you're kind of thinking, and she was 26 years old, like, why is she hiding under the bed? What they found out later on, the staff said, was that she, as a child, had been sexually abused, and one of the ways she protected herself was to hide under the bed. So sometimes people are doing the best that they can do, and yet it doesn't look like probably the way we want people to act. Some of the key principles of trauma-informed approaches are, and this can be really a culture shift, and I'm going to guess that many of you all have done some of this already. So you want to recognize the impact of violence or trauma on coping strategies. Again, people are always doing the best that they can do. It identifies recovery from trauma as a goal. And here's the good news, is people do recover from trauma, and with the right help. It works from an empowerment model. It maximizes consumer choices. Many of our clients have not had any choices, and so when you give them a choice, that creates a trauma-informed approach. It focuses on relational collaboration. That's a fancy term for some people, relationships are important, and Stephanie Covington talks a lot about this in terms of women in trauma, and she said that it's really important that relationships are important to women, and we need to teach people how to develop relationships, with their children, with families, with their community, and those are some of the things that that come to mind. There's also some more principles, and as you know, many of your clients have a lot of strengths. To be able to survive and be homeless really is a lot of survival skills. So we really emphasize some of the strengths that people bring. We like to minimize the possibility of re-traumatizing, and again, really striving for cultural competence. So you look, for example, and different cultures may have different ways of viewing traumas, but also many different cultures may also seek different ways of healing. So for some people, therapy is going to work. For some people, prayer will work, and so we want to really take that into account. And bottom line is, we also want to ask and get some consumer input, because really, who's the customer? Our clients. So here's a couple of things that you can do. And one of the things about trauma-informed care, a friend of mine was telling me a story, and she's a yoga teacher, and I was telling her what I was doing, and she said, oh yeah, they did one of those at my place too. I said, well, what did they tell you to do? They said, as a yoga teacher, if you're going to touch somebody, to ask for their permission. So you don't just touch people because you don't know if they've been traumatized before. So here's some things to do, and these are simple things. The first one is to tell people what you're going to do before you do it. So some of you are often asking people lots of questions in assessments. Sometimes you can preface this with, I'm going to be asking you some personal questions. You don't have to answer all of them, but and this may take 45 minutes. So it's like sometimes when I go to the doctor, they used to say, well, I'm going to do this, this, and this, then I'm going to put this needle in your arm. And even though I know it might hurt, the fact that they told me what they're going to do makes me feel better. Assume everyone has experienced trauma. use screening and assessment questions about trauma, and some of you may be doing that. And one of the good things about asking about trauma is that even though sometimes people don't want to answer, often people are waiting to be asked. So that's an important piece. And it's even changing the question from what's your problem to tell me what happened. One of the things that happens with many people when they've been traumatized is nobody believes them. And so by saying things like, so tell me what happened, it's a good open-ended question, and instead of saying, what's your problem? So obviously my voice tone on that one is questionable, but it's just something that opens up some of the tell me what happened, tells you where people can go. So here's just some of the components. Some of you, anybody do relapse prevention or anger management training or work with people around that? Yes, so I know that some of you do, and one of the things about trauma-informed care and sometimes working with people around what to do with trauma is you can help people identify triggers, and we'll talk about that. For those of you who do relapse prevention around substance use, we have relapse. Yeah, I knew that actually, so that's a good thing because you have LifeNet on site, which is really good. And so with substance use and even with mental health, mental illness, people will help people identify triggers. It's the same thing with trauma-informed care because people are going to have triggers, and we'll talk about what they are. Sometimes you can help people identify some of the early warning signs. Like somebody may be leaving your site and going to get a home, get a job, and sometimes they'll start to feel irritable, or if they know they're going back to their family's house where maybe they were abused, they may experience some irritability or fear, and you kind of can't figure out what it's about. One of the keys, by the way, is teaching strategies to help clients cope with triggers and to avoid re-traumatization. Now, I had this up last week, and this is really important around trauma, about staying in your lane. And what that means is that most of you probably like to help people. I won't even ask you to raise your hand on that one. The key, by the way, is for those of you who are experts in trauma treatment, I'd say go ahead and do it. If you are not an expert, it's probably better to be careful about it because you only want to work within your skill level. One of the things that happens is, I know when people are new in the field and they want to help everybody, somebody will start to tell them about their sexual abuse issues as children, and then get into trouble because they don't really know how to do that. So you can really validate people's feelings, because if they trust you and they tell you a lot of things, that's a good thing. You've obviously created safety, but you know, what can you do to validate people? So you can validate their feelings, but you don't have to be the trauma expert unless you're already the trauma expert. Here's some things you can do. Actually, as I was rereading these, by the way, these are things that we can do for ourselves. So teaching self-care, which is gigantic. Setting up calm and nurturing environments. And again, I know at your place you have them. You always have to be careful. For example, I have a friend who's a counselor, and she likes to bring in different scents, smells, or candles to groups that she runs. And so one day she brings a coconut candle in it because she liked the smell of coconut. But so she's playing, or she's using the candle in the group, but somebody who had been sexually abused, the person who had abused them had kind of a scent of coconut. So the person was re-traumatized and she didn't know what was going on. You could also teach the staff to observe for triggers or interview for triggers. You can adjust the environment where you can. You know, sometimes what will happen is, well, actually, I was thinking for in your place, you have that big room with the those chairs, those leather chairs and stuff. That is really nice. I've never seen anything like that in New York. So you have obviously adjusted the environment, and some psychiatric hospitals by the way they look at what colors are best, and so sometimes there's things that you can do, sometimes there's things you can't do. What we can do though is look at and always kind of assess what we do and how we do it. So do we speak loudly to people? Do we ask questions in a way that really could re-traumatize them? So that's something to keep in mind as well. Here's the triggers, and as some of you know from other programs, a trigger is something that sets off an action, a process, or a series of events such as fear, panic, or upset or agitation, sometimes referred to as PPT, people, places, and things. So here's some examples of triggers for trauma. So why don't you take a look at that, and since you've been sitting for a while, what are some of the things that stand out for you? We can go over this, but what are some of the triggers that stand out for you as you look at that list? Anything that stands out? And this list, by the way, oh, bedtime. Yeah, that's a big one, especially in places like yours or residential treatment. And one of the challenges for bedtime is that you have bed checks. And sometimes when people have bed checks, that they can be re-traumatized again. I see engaging in sexual, in sexual behavior. What that sometimes can mean is sometimes when people have been abused and then they get into another relationship, that sometimes they get triggered by having sexual relationships with people that they want to have sexual relationships with this. So it becomes almost a trigger. It used to happen a lot when people had gotten into recovery from cocaine, or they had been sex workers, that can be a trigger. One of the things sometimes too is some things you can change, sometimes things you can't. So large men, so if you're a big guy, you can't always change that, but it's sometimes to be aware that sometimes when you get into people's personal space, that they may be re-traumatized by that. Also yelling, sometimes too, let's say for example there's a fight at the at your place, that sometimes just hearing other people fight can be a trigger for trauma. Being confined in a small space such as an exam room. So sometimes if people have gone to the doctors and they're in a small space and the doctor asks them to remove their clothing, which is right opposite that can be a trigger as well. Being asked personal questions for an interview, again, can be a trigger. Particular time of the day or night, time of the year, and that might correspond to when the person was abused, contact with the family. The smell, by the way, is one of the biggest triggers for people, actually in terms of relapse prevention, in terms of getting re-traumatized, because one of the things that happens with smells is the sense of smell is one of the oldest sense that we have, and sometimes you smell something and it just brings you back to anything that you associate it with. So, you know, if we talked even about smells that you like if you're let's say your mom was a good cook and she either made fried chicken or whatever she cooked, the smell of fried chicken might bring you back to where you were. The challenge is that sometimes the smells that people have dealt with while they were being abused also bring them back. So let's just say you go to work and you're wearing like a new scent that somebody gave you, and you have no idea that the person, some of the people who you're talking to may be re-traumatized by some of the smells that they experience. So it's why sometimes you have to be careful about different perfumes or aftershave lotions that could traumatize or re-traumatize people. So these are just some of the probably the examples of the triggers. What I'm going to ask you probably on the next slide is, can you think of triggers that your clients experienced that were not mentioned on the prior slide? So what might be some of the triggers that may be typical of where you are at the bridge that could re-traumatize people? Oh, some of the sounds. Can you give me an example of what some of the sounds might be? Oh, sirens, yes, definitely. Traffic, the highway. So yes, those are all probably good examples of different sounds that people have experienced. So yeah, and some of those you can control, some of those you can't. You know, you could just be at your site and hear sirens and people may start to, oh, guns, gosh, yes, definitely. So the sound of gunshots, and, you know, it reminds me of an example when I was training this in New York where somebody said, well, you know, in my neighborhood I heard the sound of guns all the time. So I didn't feel like it was traumatic. I just thought it was like part of everyday life. And what I was trying to explain too is just because something is part of everyday life doesn't mean that it's not traumatizing. So we don't want to really minimize any of the sounds or some of the things that are part of people's everyday life, because they may need help with trauma on that as well. Can you think of others? So you went with sounds when you came up with a variety of things. This may not be true for your agency, but I was working for an agency in upstate New York, and they had the security guards change the uniforms to the exact same uniforms that the police in that town or city wore. And what people were saying was actually seeing police and police uniforms was really traumatizing to them. So that was like another example. Can you think of others? Oh, balloons. Balloons again, we're just kind of sticking with the sounds of the balloons, or sometimes there are people who are afraid of balloons, but sometimes balloons bursting may sound like gunshots. Or it reminded me of on the 4th of July this year, oh, seeing balloons. Ah, and what is that about, seeing balloons? Oh, the colors of the balloons. You know, I'm going to ask the next question be, what about the colors of the balloons? Sorry, I'm being a pain on the questions. It's just that I can't see you and you can't see me. That, oh, no color. Oh, colors, that's a different response. Thank you for making that. Right, so the actually colors again, thank you, Sarah, for straightening that out. So obviously two things. So the balloons can be a trigger for trauma. Different colors can be a trigger for trauma. I was thinking too, going back to the sound example, is this year on July 4th, when people always like to have firecrackers or actually go to see fireworks, is that they were saying if you knew anybody from Iraq or Afghanistan who would just come back, that beware that they might be traumatized or re-traumatized by the sounds of the fireworks. So sometimes things that we think are fun turn out not to be as much fun. So those are just, again, some of the examples. I was thinking too, there's a lot of triggers for people who are veterans. I was driving last week and I was remembering a story of what a guy told me was that whenever he would drive in Iraq, is he would always be really careful of garbage in the street or garbage bags, because he thought it might be a bomb, and so he wouldn't drive over a garbage bag. And so when he got back to the States, and he'd be driving and there'd be garbage in the street, he was terrified or re-traumatized every time because he thought it was going to be a bomb. He also struggled with going to the supermarket because his job had been to look at bombs and find bombs in Baghdad, in the city. And so when he would go up and down the aisles of the place of the supermarket, he would have to really like look behind everything to see if there were bombs. So those were just some of the things. So there's probably what you could think of, you know, as you go along, is looking at what are some of the things that can trigger. And sometimes there are things you can change, sometimes there are things you can't, but just to be aware of what they are. Here's probably one of the pictures, and I know we still have about 8 minutes, but one of the good things is that there really is hope, and that people do get better from trauma with help. And many people, you know, people are resilient. And if you look at things like resiliency factors, it could be anything from social support, actually from having a job, and we'll talk about work on Thursday, from having friends, from having a sense of spirituality, for having things to do and having some of the structure. And again, there is hope that people can work with. Some of the conclusions, and some of you know this as we've gone along, is most clients really have experienced trauma. You said that. Trauma influences, again, how people access services. And a lot of times people are afraid to access services because of their trauma. Responses to trauma are always adaptive. So again, people are doing the best that they can do. It might not look the way you want people to act. And trauma survivors require specific tailored interventions, so that the term trauma-informed care can be applied to any agency. It looks at how you create safety for people. The term trauma-specific interventions are interventions that are done by people who have the skill or the capability to work with people's trauma. So that's sometimes one of the differences. Actually, it is the difference between a trauma-informed care program and a trauma-specific program. So what questions do you have on trauma-informed care? Please write in any questions that you have on trauma-informed care. You know, sometimes maybe because I'm from New York, I speak a little quickly to get through the material in the hour. But what questions can I answer while you are there? You know, I can give another sports example, but I don't want to re-traumatize anybody. But I remember when I'm a basketball fan also, and so when DeAndre Jordan was going to sign with the Dallas Mavericks, I was like really excited because I knew I was doing a lot of work with you all. And then when he changed his mind and decided to stay with the Clippers, I felt like semi-traumatized by that. But I don't know how people in Dallas are feeling about that, and or how Mark Cuban is feeling about that. But that's something that came into mind around some of the traumas. They've even done studies, by the way, and this might be not so much about trauma, but this is about depression, that sometimes when teams are in Super Bowls, the team that loses, the city the next day often deals with depression for a couple of days. The city that wins the Super Bowl usually deals, obviously, with some joy. But they have done some studies on that. It may be traumatic for some people, but it may result in transient depression. So what other questions do you have? Questions, comments, loose ends? Oh yeah, oh actually that's a good question. Has anyone ever been traumatized by the picture? Oh, nobody has said something, but I'll tell you why it's a good thing, or it's a good question. When the DSM was revised around trauma, they said that if you were watching television or watching scary things like, or movies, that didn't count as trauma. The only time it counted as trauma is if you had a job where you had to look at pictures of people who had been abused or killed or maimed, or there were some people who had to work and look at pictures of child pornography as part of their job, and that would count as traumatizing. I guess the question I could throw out is, do you feel traumatized by the picture of the world burning? Should I change it for next time, for my next training? Oh, John Burton likes it. Okay, then John, thank you. I think we'll keep it. If you have other ideas, you can always let me know. But it really is a challenge around what we choose to put up. Sorry, I'm laughing because I'm glad John Burton likes it. If you want to email me about anything, that's my name, and there's my email address there. And I hope it was helpful. I enjoyed being here with you all, and look forward to working with you again. So thank you very much, everybody.